Perfect.
Good morning and Happy New Year, and welcome to our monthly live broadcast from Mount Sinai Fuster Heart Hospital from the endovascular division from Mount Sinai, New York City. This is our first broadcast for this year, so we're happy and excited and refreshed. I'm your moderator for the day, Vishal Kapoor, with my partner, Dr. Karthik Guja.
Good morning.
So we'll be today moderating for a very exciting case, again led by Dr. Krishnan and Dr. Raman Sharma. So before any further ado, let's go to the lab. Morning, PK.
Oh, good morning. Good morning. We actually, Raman and I were just commenting how handsome the two of you look. I'm sure the audience.
Thank you, PK.
The audience is like, my goodness, you're going to get a lot of likes on your Twitters. But anyway, so Raman and I are here, schlepping it. We're so happy New Year to all from Raman and me. But I want to introduce our team first. To my right is Moin Saidin. He's our endovascular fellow this year. Behind Raman is Ray Lascano, who had a wonderful New Year, looking happy. We have Alina, who's our nurse extraordinaire, and then we have Mac, who needs no introduction, and then we also have Damien here, and with us. I think Damien's the only tech, right? We don't have two techs. Okay, good.
Oh.
So anyway, we're ready to start, and I guess we're gonna, Raman's picked a great case for us to start the new year off with, and I think it's kind of, when we sent out the survey last year, ourselves and our administrators, a couple of things that came back to us, at least to me, I haven't shared it with everybody, is calcified SFAs, occluded calcified SFAs, iliac calcification with occlusion, below knee CTOs, critical ischemia, alternate access. These were kind of the top of the line. And it was funny because when we were looking for the case, we had a gentleman who was very complex. Unfortunately, he couldn't make it. So Dr. Sharma was kind enough to find this case for us, and we're ready to go. So without further ado, Moin is going to present the case, and we're going to get started.
Thank you, Dr. Krishnan. So let's go ahead. Can we move on to the next slide, please? Yeah. So today we have a 74-year-old gentleman who's referred to our PAD Center for progressively worsening left lower extremity claudication, which has been worsening with conservative therapy over the past 6 months, Rutherford Category 3. He's been on maximal medical therapy, and he's been undergoing a supervised exercise program. In terms of his past history, usual risk factors for someone with PAD, hypertension, hyperlipidemia, non-insulin dependent diabetes, is a former smoker, and he has polyvascular disease, known prior CAD, had a PCI to the LAD in the past, and he had a prior PTA to his right SFA in the past at an outside hospital. In terms of his medications, he's on aspirin, he's on atorvastatin 80 milligrams, metformin, and cilostazol. In terms of his vitals, he's hypertensive, blood pressure 150 over 70, saturating 98% on room air. In terms of his focused vascular exam, he has non-palpable and non-dopplerable DP bilaterally and palpable PT pulses bilaterally. Labs, hemoglobin is normal 15.1, creatinine is normal 0.8. In terms of his ABI, right is 0.8 and left is 0.62. He had an arterial duplex at an outside hospital that was notable for an occluded left SFA and a left AT were occluded in the mid segment, and he has monophasic waveforms in the left popliteal, anterior tibial, and peroneal artery. We did a diagnostic angiogram on him when he came in last week. This is his inflow. It's some aneurysmal disease in his left bilateral common iliacs, and some mild to moderate disease in the iliacs, but inflow looks pretty good. Here we have still images of his occlusion in his left SFA, which is a CTO in the proximal SFA with a tapered, likely favorable proximal cap, reconstitutes distally above the adductor canal in the distal SFA, and essentially the infra-pop, he has a two-vessel runoff. The left AT is occluded in the mid-segment, and the peroneal kind of tapers off with the posterior tibial as the dominant supply to the foot. In terms of our case plan, we plan to go actually right femoral artery, 7 French up and over. Possible retrograde distal SFA, since he has a single vessel runoff with the PT is the dominant runoff to the foot. We're likely going to cross with a stiff glide wire, which is our algorithm here. And then we try to re-enter distal SFA just prior to where the SFA reconstitutes, hopefully preserve the option for a FemPop bypass in the future if this intervention fails. We'll plan to do IVUS guidance into distal embolic protection. In terms of vessel prep, we're thinking IVL versus atherectomy, and we'll have more information on our plan for either DCB, DES versus a Supera stent.
I think it's a phenomenal presentation. I think we'll stop here because Moeen has actually prepared some stuff. So when we get started, let's start with Raman. I mean, it's your case, buddy. I mean, what are you thinking? How are you going to cross? And then Vishal and Karthik, why don't you guys let us know what you think you guys are going to do?
Yeah. So I think, Moen, again, that was a really great summary of this guy's case and kind of what our plans are. And we've already kind of begun just a little bit kind of the same basic initial strategy that we usually have with the 035 transit catheter system. This time, instead of having a vertip, we actually have a glide catheter. We have a stiff angle glide wire. Now, the interesting thing is that, the proximal area from 1 to about 10 is looking pretty easy, pretty favorable. No real dense calcium. But after 10, all the way until where that distal reconstitution, this is just is a big rock. I think crossing this is going to prove to be the most challenging part, and it kind of will also decide what the destination therapy is. Because crossing will then decide how we're going to end up crossing. Are we going to be very subintimal? Are we going to have to use a reentry device? Are we having to do direct SFA access? I mean, all these things are just kind of the things you just think of before you've even tried. And I think the question is now, try integrate for a reasonable amount of time, go down the basic algorithm with the basic wire escalation. Then from there, at some point, decide to say, let's go down one of our alternative axes, or maybe even try one of our reentry devices. Right. The iliacs, we didn't show this, but offline there was yes, there were no clear obstructive disease, but not a very favorable arch to actually get our 7 French sheath all the way across. It was a little bit of a challenge, so that would kind of make using one of our reentry devices also a little bit more challenging. Right. But we do have a 7 French system, so we may have be able to do it.
So Vishal, that's a great summary on Raman's plan. I mean, as Raman, are you going to go with 035 Raman just to start? Okay, so Raman.
Yeah, can we see the pictures real quick? The angiogram runoff. I think, because I think one of our audiences did comment well, which I think is great. Is this is a very good real life situation we most of the times see. I mean, I know with live cases we like to do the most complex stuff, but I think this is really complex enough in a regular community, regular real life cases. So what you're presenting is a great information of how to deal with it. The only question, I guess, once we want to start to see how the cap is, because like how Raman is talking about going antegrade versus retrograde is a lot determined by how your proximal cap and distal cap is and your chances of success of crossing. So I think if you can, so that's the good runoff to see.
This is I guess the prized image, right? You see the distal, you see the proximal cap with that negative subtractive image, and then you have the positively subtractive image over here, and it's a pretty short segment, about 10 centimeters.
It's a type 1.
It's a true calcified segment. But this is a rock.
So that's the question here as he's going to get started for the time. Let's Ray, can you give some pressure there? So as he's going to start to see whether we can subintimally or get through this. The nice thing is you have the calcific shadow. Karthik, I know you're a proponent of the 018s. Would you use an 018 here, or would you go with an 035?
No, I think this one, as Raman said, PK, it's very calcified. Again, I don't think this can be crossed lumen to lumen to try even 018. I think this needs. I think you crossed it.
Except today, which is good. So listen. Okay. Let's.
No, but that's one of the talks. Yeah. Go ahead.
But Vishal, what I want to do is, because one of the things that even Moeen asked us, which was very interesting, is what's the story with our wire choice? He's like, Dr. Guja does this, you do this, everybody does this. So let's talk to our audience, because we do have quite a lot.
Yeah, just wanted to say Raman could have made it look a little more tougher, so would have been nice. So.
Well, listen, if we need toughness, we usually ask Vishal to come. Vishal is here. It's always tough. So
I thought we were going to have a lot more to do.
Look, enough kidding around. Let's talk here.
Yes.
So I want to know, from you guys, how do you choose the wires? While Raman gets the filter down and we do the IVUS, I mean, how do you guys choose the wires?
So, Karthik, you want to?
Yeah, I usually choose if I want to be luminal, if I feel like there is less calcification, and I feel like I can dissect it, micro dissect it, and then get into the vessel with 018. I use 018. 014 pretty much never for SFAs. But if I feel like it's a long segment calcification, I know I'm going to dissect it. I know my therapy is most likely going to be either a long DCB or a stent or IVL. Then I just dissect the vessel through and then go through. And calcification, of course, 035. That's basically, and antegrade versus retrograde depends. This case, I would have definitely prepped the pedal vessels as you guys discussed, and I think direct SFA. I think once we have gotten very good with the pedal techniques and the retrograde techniques, I think direct SFA is pretty much been non-existent, at least for me in the last couple of years. So.
No, I mean, I think, PK, that's a great conversation to have is the wire selection. I mean, here at Sinai, we are thankful enough that we have all the wires around the spectrum. But it's a very good, important topic. Like the only time Karthik and me have a little bit of discrepancy is the wire selection, but otherwise we agree on everything. The question really arises, like you say, is crossing these calcified lesions. I agree with you, going up front straight 035, which I would take it a stiff angle glide wire, go across, and then we just do it. Because again, we know that the data suggests, and me and PK talked about it actually yesterday as well, there is no difference between going intimal versus subintimal. So connecting lumen to lumen, I know it feels great for us because being an interventional cardiologist and doing coronary work, we want to stay lumen to lumen. But truly speaking from an endovascular perspective, lumen to lumen doesn't really matter. You can go subintimal and the results are exactly the same. So talking purely about the long-term outcomes, which is what we are working towards for any patient and our stuff, I don't think there's any difference between going subintimal versus lumen to lumen. So I think that is probably not a consideration. For me, it's more about the cap. So sometimes, remember, you have a blunt cap, which has a collateral coming right across it. It's like flush occluded, and I don't have a beak to poke in. So what I would do is in those cases, specifically when there is no channel, lumen, or beak, let's say CTOP classification 4, which all complex is not favorable, then what I do is I use an 018 wire, pretty much like creating a channel or a hole where I can get some of my support catheter like abutted in the lesion, and then we switch over to an 035. That's my usual strategy. Otherwise, 035, most of the times, like you said, like Raman showed very elegantly in this case, however calcified it might look, you can actually push it, create a good loop, gives you more pushability, and you just cross over. So that's usually my strategy, unless PK, you would like to comment.
No, I mean, I brought that up because Moeen actually asked me this question a little while ago, and I can tell you that, listen, all of you guys are incredible operators, and I think the fun part is for them as fellows is to see different things. But, it made me think like, well, the audience also has similar types of questions. Obviously we do a lot of cases here, so it's very easy for us to say, okay, this is my algorithm. But I think the logic is what everybody's looking for, and and I think that you guys have really clearly have kind of shown your logic. Raman obviously and I just picked this wire because we kind of knew that it was going to work. We were surprised that it went that quickly, but listen, that's nice too. So we can talk about other things. So one, we talked about the wire. Okay, so pretty much calcium is a determining factor. The morphology of the cap is a determining factor, and then obviously based on that we either go with a wire escalation technique or not. But now let's talk the second thing. Raman and I have decided to put a filter. I mean, listen, we don't know whether we're going to atherectomy or not. It's a live case. I think we don't know if there's debris or not in here, but that kind of crossed the way it went. Even though he did push it, it did slide pretty easily.
Surprisingly.
So, it makes me think that there may be some debris in there as well as other things. I mean, normally, as all of us have done these difficult cases, you see it buckling. You have to take the catheter close. You have to give a lot of support for it to cross. Here, the catheter really kind of conformed to the vessel and went. So that's kind of our reasoning for putting the filter. But also talking to you guys, do you guys use filters when you're not going to atherectomize, or do you say when you look at a lesion like this, you make a determination and then decide to use filter? Because our paper was only about atherectomy and filter use. It was about atherectomy, not about general stuff. And in this case, we don't know, like Raman said, our destination therapy till we do the IVUS. So explain to me on how you guys decide the filter. I'll ask Karthik first, then Vishal, then Raman.
Yeah. So PK, I stopped using filters if I'm not atherectomizing. This case, we already know, and it went easy because I think Raman did really elegantly showed how you can dissect an SFA and get into the true lumen with very easy technique, which is wire loop technique, right?
A little lower, right?
So
lower.
Here, most likely what you should do is, I would have done is do an IVL and probably balloon stent it because it's a reasonably short segment of CTO, and I think you can get away with like 200 stent, and the runoff is pretty reasonably good.
I got to tell you, Karthik, that's the first time I've heard a 200 stent is a short stent.
I know, but see, the question is, 200 stent is a short stent, but you have to understand it's so calcified. You cannot, even if with IVL, unless you do a DCB. Now we have DESs, which are really, the patencies are really good. So I think for platform here would be a great idea. I think I'm just looking at the patency of the vessel, and the runoff is good. But I would IVL and DCB and seed. If I get a good result, it's great. I would take it, but
has your, before we do that, let me go to Vishal. Vishal, what about you?
No, I mean, I agree. I stand by the paper we had actually published. If we are doing an atherectomy, especially in a case like this, where the debris burden is there and we know the outflow might get compromised, I would definitely put a filter in. But if your strategy is just doing, let's say, an IVL stent, then I would probably not add on to the more expense. The advantage of using filter in that way probably doesn't add on much to it except for the cost. But otherwise, if you're doing an atherectomy, whether it be directional, orbital, or aspiration with thrombectomy, I would definitely put a filter in. So that is my usual strategy or my protocol, you would say.
Raman, as we do the IVUS, why don't you tell us?
Yeah, I mean, I think if once you've been burned by not putting a filter in a long segment CTO case, calcified, not calcified, I think once you've been burned like more than 5 times,
right there.
I think you just
even
reflex.
once is too much, right?
Yeah, I think you just end up just doing it. I mean, like the overall cost of adding a filter is like, yes, it can pile on, but it's not the most expensive thing. There are wires we use that are more expensive than a filter. Yeah. You know, I think at the end of the day, you know, like if what you're talking about is like removing an hour and a half of salvaging, tibials going out. You know, what's the harm?
What's the harm?
I think in a case, I think in my practice, a long segment CTO invariably gets a filter.
Okay. So here's the IVUS. So let's go, Ray or Raman, can you do a pullback? I don't know who's closest.
Yeah,
let's do a pullback here.
PK, I know you put a filter for every long segment CTO, right?
I mean, listen,
no, he doesn't.
I agree with Raman. I agree with Raman. I think that, you know, the idea of getting burned it's happened to me quite a bit, and you know, it's you spend hours and hours doing that, and you can see in the pullback that Ray's doing, you know, you've got a lot of, you know, speckled and a lot of slight highlights, but you don't see there's some mobile debris right there. There's another one. So, you know, you've got a little
there's
bit.
There's the calcification.
Heavy calcification, we know. But you can see that the crossing has really been pretty, luminal, which is very nice. Yeah. But we're not there yet. We're going to keep going back.
That's tight. Yep.
It's all very
so
tight.
very, very tight. Keep coming back. Yep. So we're going to keep coming back here as we show the calcium. Again, there was debris distally around 20 to 25. Right now, there's no debris here. It's just straight calcium. Mark all that, guys. We're just going to keep pulling back. And there's some calcium and soft plaque, which we don't know, might be mobile.
It's a mixed morphology, right?
It's a mixed morphology,
Yep, but there was clearly mobility distally.
That also explains how the wire kind of knuckled and just kind of made its way across.
Yeah.
If this was pure, just like dense calcium, we would be still working on
That's
that
very,
aspect.
very tight.
But this is really good though, because so far we have intravascular evidence to show that the entire cloth was purely luminal. There's any real place that we're very deeply subintimal. I will just go back to the one topic we were talking about earlier about the intimal or subintimal versus not. I think that's
Mark that, guys.
True to a certain point. I think once you get to a point where your cross is beyond just subintimal, and like you're almost like getting like the media into almost the adventitial. That's a little bit of a different scenario, and you see that a lot in these highly densely calcified lesions, where when you're actually crossing, your wire is looping around the actual vessel, and that dramatically changes the way I think you would decide on your destination therapy. So I think I agree to a point that luminal versus not luminal is like, you know, is not that big of a deal, but there is a point at which it is.
But the data still doesn't show it.
Yep, data still doesn't show it. I agree.
But clearly, I agree with you. It makes intuitive sense that a luminal cross would be better. But I just have a question. Now we've all agreed to disagree on filter. Except 3 of us would use it. One may or may not use it depending on what they.
No, I use it if I was going to atherectomize PK.
Right.
I would. But if it's IVL, IVL has clearly shown that the amount of embolization is very less with IVL, right?
Exactly. So the question now is, you've done an IVUS. Now it's Raman's case, right? It's this patient. So Raman, you've done an IVUS. You've gotten the things. What is your therapy? Because Moeen's done a nice little presentation on it, which he's going to prove us all wrong on what we should do. So right now, let's take a vote. Raman, looking at the IVUS and looking at what you've seen, What's your therapy?
Yeah. So first, given how tight it was, probably begin with a little bit of pre-dil to help the IVL catheter make its way down. So probably go with a long PTA balloon, 4.0 or so, to help the crossing of the IVL. Definitely we'll get IVL. Sizing wise, it looks like 7.5, which is surprising. What level is this? This is at the.
This is
distal?
proximal.
No, distal.
Oh, this is distal. Wow. So make it a 7. This is pretty big.
Okay, then.
Actually,
So
make it a
IVL.
6.5. And I would also do some atherectomy.
IVL, and then you do atherectomy,
IVL,
and then followed by
DCB,
DCB.
and then spots.
And then possibly
probably
spots
Supera stent, probably just the CTO segment. We'll probably have to do a Zilver for that proximal part too.
Okay, so one is obviously a vessel prep with IVL and atherectomy, and then DCB delivery with spot stenting as needed. Vishal, and then Karthik.
For me, exactly the same. I'll do IVL, atherectomy, DCB, and spot stented wherever it needs to be done.
Yeah.
And then Karthik.
I would IVL it and stent it.
So just direct
DS.
with the DS.
Yeah.
Okay.
I mean, there's a good argument for that too, right? Because this guy had the right SFA done about 6 years ago, and he had like some moderate lumpy bumpy on the right side. So we know if he serves as his own control, that he's not one who has a huge preponderance towards ISR. So I mean, so that's also perfectly reasonable.
So now
That was me agreeing with you.
So now I'm gonna ask Moeen to do his presentation.
No, I think you can go either ways. I think if you get a good result with DCB, you can just keep it as a DCB result. I think you might get a good remodeling.
You know what? For me, I can tell you very clearly that I think that there's no role for atherectomy here. I think that I think that Silverhawk, Rock Hawk, or whatever hawk you want to call it, has really been something that you already down there. That really been something that was at that during the past was good. I think this is how it goes. Isn't that it right there? Yeah. It was good. Wait, this is the BD balloon or what?
This is the Ultraverse.
Armada, that's what I thought. It's only single. So I think that I don't think there's a role for atherectomy unless you're going to do a jet stream atherectomy here. But I think here it's probably
Your balloon is already down there, PK?
Yeah, we're already down there.
Yeah, that's
So-
the PTA balloon.
It's just,
so much
it's just
outside.
we're going to pre-dilate here. So now I'm going to ask, while Ray, can you set up the IVL? I'm going to ask Moeen to present as we do the vessel prep here. Moeen, what are the choices we have? Because based on his lecture, we'll take it from there. We're with the right spot, right? 20? Come back a little, right? Right there. Okay. Show me above where we are.
Can we have the slides back up?
Okay, good. 6.5.
No, that's tight.
Mm-hmm.
Can we have the slides back up, please?
I wouldn't even IVL.
This much calcium, I think you have.
It's a circumferential calcium.
Yeah, but you've expanded it with the 6.0 balloon.
Oh, well, that's true, though.
4.0.
This is 4.0, PK. Yeah.
So then go with the 6.0. 4.0 expand, 6.0 expand. Okay.
I'm just gonna go over the contemporary therapies for SFA popliteal lesions. We have a lot of options, as we can see on this slide. In terms of therapy, we have drug-coated balloons. We have 3 platforms available in the US. We have the Lutonix balloon from Bard. We have the Impact Admiral balloon from Medtronic, and we have the Ranger balloon from Boston Scientific. Then we have the standard nitinol stents, which are kind of been phased out with the newer generation stents, the drug-coated stents. We have 2 platforms of drug-coated stents available, the Zilver Pmhx from Cook and Illuvia stents from Boston Scientific. And we also have the covered stents, the Gore Viabahn covered stents, and we have the interwoven nitinol stents from Abbott, the Supera stent. So I'm just gonna go over the overall 12-month primary patency rates for all these different therapies for SFA. As we can see on the extreme right, mostly in kind of simple lesions, which are not occlusions or calcified or CTO lesions, the patency for just drug-coated balloons is pretty good in range of around 90% at 1 year. And for the Viabahn stents, it's around 68 to 70%. And for the Supera stents, which included more complex lesions, the patency is around 90%. And for the drug-coated stents, it's around, Zilver has a patency around 83 to 85%, and Illuvia around 90%. So I'm just going to go over the individual data for all these therapies. So first is the SUPERB trial. This was a single arm study compared to PTA performance goal. It's a US multicenter unblinded single arm study that enrolled patients essentially who had like long calcified lesions. 72% of the lesions had moderate to severe calcification. The mean lesion length was around 8 centimeters. Most of the lesions were in the mid or distal SFA. 264 patients were enrolled in this trial, and as we can see, the primary patency around 90%, which is very good. And at 2 years, freedom from TLR was 84%, and most importantly, there's 0 stent fractures at 1 year with the interwoven nitinol stent. So in terms of patency with regards to the lesion length, the lesion length really didn't matter with these interwoven nitinol stents. It was around 87 to 88% irrespective of the lesion length. As we can see, even with very long lesions around 12 centimeters, the patency was very good. But the patency is dependent on the deployment. With nominal deployment, we get around 90% patency. But as we elongate the stent, the patency rates go down. So the key to patency with the Supera stents is nominal deployment
Want to do it again?
and adequate vessel prep.
6.
And here we can see freedom from TLR over time is around 95% at 1 year, and it kind of is very good even up to 3 years, around 88%. So the next study I'm going to talk about is the RCT that compared the Zilver PTX to PTA. This was a multinational, it was a randomized prospective trial that compared DES to PTA, one-to-one randomization, around 236 patients in the DES arm and 238 in the PTA arm. As we can see, the primary patency was extremely good, around 82% at 1 year, but it really goes down at 5 years. It's only 66%. And the lesions included in this trial were not very complex, very few calcified lesions, probably in the range of like 20 to 30%. As we can see, the main Achilles heel of the DES stents is the primary patency goes down as with time. It's only around 60% at 5 years. Though it's extremely good at around 1 year, it's around 82%. As we can see, the baseline characteristics of patients in this trial, the average lesion length was not very long. It was 6.6. It's not really real world. Very few occlusions, 33%, just a 1/3, and severe calcification only in around 40%. Most of the patients were claudicants, very few CLI. The real PTX trial was one of the first trials that compared DCB to DES. This was another randomized trial, which essentially showed no difference between DCB and Zilver PTX at 1 year in terms of primary patency, but the better durability of DES at 2 and 3 years. There was a large drop in patency with both DCB and DES in long lesions. So here again, we have the data comparing DCB to Zilver PTX in the real PTX trial. As we can see, there's not a lot of difference here in terms of primary patency, but the patency goes down as the lesion length increases and with time as well. So in lesions more than 20 centimeters, the patency is around 75% at 1 year compared to 90% in lesions less than 10 centimeter. So next I'm going to talk about the Imperial trial. This was another randomized prospective trial that compared the two DES platforms available in the US. It was 2-to-1 randomization between Illuvia and the Zilver PTX stents, which essentially showed a superior primary patency for Illuvia compared to Zilver PTX, and non-inferior in terms of major adverse events. Illuvia also had lower TLR rates and stent thrombosis than Zilver PTX. So here we can see the difference between the two DES platforms, the better primary patency for Illuvia and more from TLR for Illuvia compared to Zilver PTX. Those are the results there. Next, I'm going to talk about here again. Again, we see the 2-year results for different subgroups of patients in the imperial trial. In the diabetic subgroup, the moderate to severe calcification subgroup, and the CTO subgroup, the patency kind of goes down, which is the main limitation of most therapies for SFA is long lesions, CTOs, and moderate to severe calcification. As we can see, the patency is around 75% in these complex lesion subgroups with DES platform. So this is the Viastar trial, which essentially this was a trial that compared our Viabahn stents to the bare nitinol stents. This was also another randomized multicenter study. The primary patency was numerically higher for the Viabahn stents, around 71% at 2 years compared to 71% at 12 months and 63% at 24 months. This was better than the bare nitinol stents. But in terms of freedom from clinically driven TLR, there was not statistically significant difference between the Viabahn stents and the bare nitinol stents. That's the comparison in terms of primary patency between the two subgroups: 71% for the Viabahn and 63% at 2 years. And then I'm going to move on to the DCB trial. The Impact SFA was one of the was the pivotal trial, the major trial that led to approval of the Impact DCB in the US. It was a multi-center randomized trial, single-blind, comparing DCB to PTA, which clearly showed superior results with DCB with 90% primary patency at 1 year and 70% at 3 years, and freedom from TLR was 98% at 1 year and 75% at 5 years. As you can see there, comparison between DCB and PTA, clearly superior results for DCB that led to approval of DCBs here in the US, 90% at 1 year compared to only 67% for plain PTA. In terms of characteristics of these patients enrolled in the Impact SFA trial, the lesions were not very long, around 9 centimeters, only 20 to 26% occlusions, not a lot of severe calcification. Most patients were claudicants and not CLI. In terms of for the long lesion cohort, clearly the Impact long lesion cohort shows that the patency rates do go down with longer lesions, more than 25 centimeter compared to 15 to 25 compared to the shorter lesions. So the primary patency is around 98% for lesions between 15 to 25 centimeters and around 80% for lesions more than 25 centimeter. Importantly, even in the long lesions, just with DCB, there's a very high rate of provisional stenting, around 40% when we use DCBs. These are the results of the Ranger 2 SFA trial, which compared the Ranger DCB to PTA. This is a low-dose paclitaxel with 2 micrograms per millimeter square. This showed excellent results at 12 months with primary patency around 83% compared to 66% for PTA arm. Here we can see the comparison between DCB and PTA, the primary patency around 90% for DCB and 74% for PTA. This is the only trial that actually compared a head-to-head between the two DCB platforms available in the US, the Ranger and the Impact DCB, essentially showing no difference between the two DCB platforms. Primary patency is kind of in the similar range, and between the two DCBs, both the Impact and the Ranger DCB, primary patency around 88 and 99% in 1 year and 71% at 2 years. So essentially no difference between the two DCBs available in the US. So now I'm going to talk a little bit about the new kid on the block, the PTAB, or the endograft system available from Endologics, which is essentially a percutaneous bypass that uses a femoral vein as a bypass conduit, essentially completely bypassing the long occlusion. As we spoke about earlier, the main Achilles heel of SFA interventions is the primary patency goes down with complex lesions, long lesions, and calcified lesions. In these kind of patients, though open surgical bypass is an excellent option, the recovery times are longer and the morbidity, and not everyone is a candidate for surgical bypass. So So in this system, which is the PTAP percutaneous transmural arterial bypass, they use the torus stent graft system essentially to do a percutaneous bypass through the femoral vein, and they included extremely long lesions in the range of 20 to 46 centimeters, most patients had prior endovascular procedures and were unable to undergo an open surgical bypass. So with PTAB under fluoroscopic guidance, the detour system essentially creates a FemPop bypass routed through the femoral vein, delivering flow from the SFA to the popliteal artery. So in this single arm multi-center prospective study that led to its approval in the United States, 202 patients were enrolled in this trial with 36 sites, and the primary safety endpoint was major adverse events at 30 days, and primary efficacy endpoint was patency at 12 months. And the plan is to follow up these patients at 30 days, 6 months, 12 months, 24 months, and 3 years. And it was a extremely well done single prospective study. It included a duplex core lab, angiographic core lab, a clinical events committee, and a data safety monitoring board. So as we spoke about, like the kind of patients included in this trial were very unique in the sense that they were most complex patients that we see. These are like very long lesions with 32 centimeter mean lesion length, CTOs 96%, and 17% of patients enrolled in this trial had stent restenosis, and 60% had a prior endovascular intervention. In terms of baseline characteristics of patients included in this detour study, extremely complex patients, as we can see. Most of them had the usual risk factors: diabetes, hypertension, hyperlipidemia, renal insufficiency in 10% of patients. As you can see, most of the patients at CTO, very high burden of calcium, CTO lesion length very high, 21 to 23 centimeters. So there's very high procedural success rate. We've had experience here at Sinai doing these procedures. We've done around 3 to 4 of these a couple of months back, and we had excellent results. So 98% success rate with this procedural success with delivery of this device, and very few adverse events, like infection rate in the study was 0.5%, and freedom from major adverse events at 30 days was 93%, and 1 day of average hospital stay. And most patients were who underwent this procedure in the study had improvement in the Rutherford claudication score, as we can see there, even up to 2 years. So that's it for the contemporary therapies for the SFA. So back to you, Dr. Krishnan.
A pretty good comprehensive selling, but then, you know, like Raman and I always say, that we're always right and Karthik's always wrong. now look at our filter. So one is we've got Goober in the filter, which was actually mobile in the angiogram that we did. So likely it's we saw it.
What did you do? So
this is right after shockwave.
Yeah. So we did shockwave of the entire proximid SFA. And this is what our DSA was post. We did it based off the IVUS room with the 6.5 IVL. Really did the lithotripsy all the way from about 22 all the way down. And as we got to the distal reconstitution, you see a little bit further down as we're looking at the filter. There's also
really nice expansion on the vessel, yeah.
At the CTO segment, it still looked pretty with pretty impressive.
Yeah.
So we're definitely going to be fixing that. But then we take this, the distal, and you see this little goober.
And the filter
jumping
full.
Up and down, and the filter is entirely full.
So we went with a 7 penumbra. IVUS first to show what the goober was. Show the IVUS, guys, so they can see the goober. Show just the goober area where the calcified plaque is. Yeah, where the calcified polarity is. See it right there?
Yeah. To be clear, goober is a
goober is a medical term.
Yeah,
it's a medical term coined at Mount Sinai that we call it the goober.
Yeah.
It's different than the boober. The boober is something that my daughter used to do when she was young. But
okay.
Too much info.
Too much information, PK.
So then we take a DSA post, thrown back to me, and the goober is no longer there.
But the filter is still full.
The filter is still full.
So the question now to you guys is, since and we'll leave Karthik out of it because he'd be fishing it out of the tibials now. So we know what Karthik would be doing. So Michelle, let's ask you. You put a filter down. Do you balloon this, or do you retrieve the filter now, or do you balloon it?
No, I just retrieve the filter. I mean, the idea, if you think the filter is still full or hasn't responded, so first of all, you did the penumbra on the wire of the filter?
Yes.
The wire next to it?
Same.
We did it on the wire of the
same
filter.
wire, same bare wire.
Sometimes you can just get stuck right at the top of the filter head.
Well, we went to the filter, but we didn't go into the filter because we weren't sure. But now the question is now, should we retrieve the filter, or do you think we balloon and then redo the penumbra?
No,
because
I think in this case you balloon the vessel well. So I would personally, if the filter is full and if let's say the filter moves for some reason and there's some distal embolization, I just take the filter out. And
okay,
then
let's go. Let's get the penumbra again.
And then we just do everything, because now all you're going to do is probably do a DES or a stenting, whichever is your.
No. Raman and I don't feel that we saw the IVUS post, which we didn't show you. Play the IVUS when, so we could see the IVUS post. The IVUS will show that there's a lot of recoil still. So.
Then we go straight up.
Well, the question is, do we go with a larger balloon? That's what I'm saying. Should we leave the filter in, put the 6.0 balloon? If it embolizes more, who cares? The filter's already full, and then we go get it. So that's what I'm kind of leaning towards.
You already use a 6.5 shockwave, correct?
Yeah, but we're going to use the 7.0 Dorado now.
But if you're planning to balloon it, you should leave the filter there, right?
Yes,
100%.
let's go.
Yeah.
7.0 balloon. Yep, that's the logic. So 7.0 balloon going in now. So Raman and I weren't satisfied with the you can see the expansion is not great. If we're going to use the Supera or any sort of stent, even a DCB, but from our paper here at Sinai, the DCB's failure is recoil of greater than 30%, right? So this is clearly greater than 30%. So now I'm just going to watch the filter as I go down because I don't want that filter to move.
Yeah.
So Raman we really don't. We know we have to go to 25 with the balloon. So 25 is in the what is it called, field. So the filter is solidly not moving, and I've got no resistance on the balloon, and I'm just coming down to 25. So, there's 25,
right?
And that's it. And now we're going to go up with the 7.
So I'm just a question for you and Raman for the thought process. So you already know after a 6.5, which is measurement-wise 6.5 shockwave, there is recoil. You're going to use a 7.0 balloon, whatever balloon you like, stiffer Dorado in this case. Would you, anticipating the recoil on a 6.5, would you just go up front with a stenting like Karthik was talking about, skip the DCB part and just do a long DES, or you'll still do a DCB, wait for the segments that recoil and then do a spot stenting? Because remember, the recoil can happen even after. So that's a question you have to think, like what layers you want to add, complexity, steps, and everything else. So that's why I want to know where you and Raman are thinking from thought process, and of course Karthik as well.
Raman, why don't you take that?
Yeah, I mean,
if a 6.5 is giving you a recoil, what's your next step?
Yeah. I mean, I'll tell you, I think there are two things that come into that decision process. The first is how long did it take you to get to that step? And the second is what time of the day is it, right? I think in this case we cross pretty quickly, and I think we're still moving at a pretty reasonable pace. I think I prefer to leave as little metal behind. But again, I think we have enough evidence right now to show that we're definitely going to be, having to leave some metal. The question is, do we bother with a DCB concept followed by Supera stenting, or do we just go straight with a DES? For this case, I would honestly say the simpler of the two options, just go and just line the entire thing with the drug-eluting stent system. But the question is, can you get away with less stent? And I think we can probably get away because you're going to end up having to stent the proximal segment. So I think in this case, if you're going to be committed to it anyway, I would not be against the idea of a long segment, two stents, 8.
Karthik, what do you think?
Can we go to 12?
And I still stand by what I said. I mean, except the filter part clearly, but I was wrong. I was wrong. I mean, when you're wrong, you're wrong. So it's okay. Right? That's what it is. You're wrong. Absolutely. You're wrong. You can't be always right, PK. So it's okay. But I still stand by my word. I would stent the whole thing.
Karthik, in this situation, I don't agree with Vishal and Raman here, and even you, because I don't think a DS is going to work here. here, because you can do the IVUS after this and you're still going to see recoil. You're not going to see a 6mm lumen all the way up. And I think, as you know from cardiology, all of us are cardiologists, the luminal gain that we achieve initially is what it's going to reduce our late lumen loss. So here we're going with a 7.0. I'm going to go with plus minus DCB. You can argue with me whether you want a DCB or not. I believe what Dr. Fallon used to say many years ago, that calcified disease may be burnt out atherosclerosis. I'm not certain that this will fail with intimal hyperplasia. I think this will probably fail by recoil. So I don't have enough data to prove it, but just some anecdotal thinking that I have. I believe that this is the best case for a Supera. I think you put a Supera in, the large possible Supera, plus minus DCB. You could say, hey, the paper that we wrote out of Sinai that Raman was a huge part of clearly showed that Supera pre-dil with a DCB reduced Supera restenosis regardless of deployment. So here I would say let's do a Supera with the DCB prep and then see how it goes. So let's take a picture here to see how our filter looks. So we're going to do a shot here.
But PK, you think Supera is only going to help because of the recoil issue?
Yeah, I think 100% is going to recoil, Karthik. I really believe it's going to recoil. Look at that. No flow now. Look at that. Wow. Look at that filter. Woohoo! That is a goober and a half. All right. So what we're going to do now is we're going to IVUS before we retrieve the filter, so we can see where we stand, and then myself and Raman are going to very carefully manipulate that filter out, God willing, and then we'll be done. We'll talk about the rest. So it looks very nicely expanded, but around 15 to 20, where Raman and I were very concerned. IVUS, please. Very concerned about the expansion of that balloon, and that's where his heart rate really went down. We're going to go ahead and look at this IVUS and then decide. So the question is, if you DCB, I mean, obviously in our lab we carry impact as our primary DCB. We have some Rangers. Anything in particular? Do you think there's a difference do you think it's a class effect? I mean, obviously, or you don't think there's a class effect? What are your thoughts?
I mean, we have the shorter term data to show that the Ranger has higher patency rates, but again, I mean, just the question is not about so much about the 1 year, 2 years. The question is what happens long term.
But I think the impact data on 150 millimeter impact data is good, right, PK? If I'm not wrong.
Let's ask our resident expert, Moeen. Moeen, what does the impact long data show in long lesion?
Yeah, I mean, obviously, for most of these DCBs, I think the data shows that it's truly a class effect with the DCBs, whether it's the Ranger or the Impact. And the only trial that compared the two DCB platforms showed essentially that the outcomes at 1 and 2 years were very similar between the two DCBs. Though the more data is available for the Impact, it's still the patency with long and calcified lesions. It kind of goes down with as you follow these patients up until 5 years. So though the 1 and 2 year patencies might be better even with long lesions, as we follow these patients up to 3 years and 4 years and 5 years, the patency does go down. So there is definitely a limitation with DCB with these kind of complex lesions, and we definitely need more durable therapies, as Dr. Krishna was mentioning. The Supera probably would be the best thing here after doing a DCB.
Yeah, I think you have to gauge your bets. So like Raman said, the contralateral leg is calcified. He did very well without much intimal hyperplasia because I think maybe the recoil was less. Same time he had a DES on the other side. So you could say that, hey, let's go with the DES. I'm just worried what if the DES pancakes doesn't expand. We have Supera here. 7-8 years ago, I don't know if we had a Supera here. So the question is just that. And I think what we'll do is we'll first handle the goober, and then we'll do everything. We'll make a decision and we'll finish up, and then we'll see how it is. So we're going to go down and handle the goober first. So I'm just going to be very carefully bringing it down. I know the wire's in a little twig in the posterior tibial. Somebody has to do fluoro, guys.
Yeah.
I just want to make sure my filter doesn't move. Okay.
Hold on.
Oh, filter's moving. Be careful.
One second.
Yeah, that's good right there.
Okay.
So I'm just going to go down close. The filter is obviously drifted down because of the flow, which the EmboShield does.
So that's an independent predictor that the filter never moves because of me. The common factor is PK right there.
Fluoro. Okay.
Just for the record, it's randomized round.
Let's see. No, I'm having issues moving this. There it goes. Okay. Okay, good. Okay. So what I usually do is when I get down here, I'm going to just ask Raman to turn that off for a second. And what I'm going to do is I'm going to have him mag it up. And we're just going to take a little road map to kind of capture the filter under how can you say, visualization. Ready? So a little roadmap here. So hopefully we can see it, Flora. So a very light injection, just to see it. Okay, there it is. There's our goober, right? So now we're just going to go under roadmap and try to suck it out. God willing, it'll come out. And let's see. Okay, ready, Roman? Go ahead. Turn it on. And let's see. I'm just going to kind of let it slowly advance here. Really try to get that goober moving. And this is the worry right here.
There's a good chance that, getting this close to the filter, this much interaction, just by that much enough, you may have caught the proximal end of that filter.
Yeah.
So no matter what we do at this point, you can really find out as you try to pull the
So PK, you're going to direction it? Yeah, I guess.
Yeah.
That's what you
Yeah.
do. Okay.
Yeah.
So I'm just going to direction it one way or the other here, just to try to get more of it.
Would you pull the wire? Would you pull the wire and then?
Not yet. I'm going to stop it here again, and then I'm going to give a little more dye to see how we've done.
Because the filter kind of slipped down a little bit, so.
Yeah.
A little bit, yeah.
A little roadmap here, Roman.
Mm-hmm.
So we might be a little better here. That was all saline, I guess.
Yeah, this is contrast. Yeah.
Sorry.
Nice.
Okay, one more time.
Mm-hmm.
Oh. Oh, much better.
Look at that.
Much better. Okay. All right. So good. All right. Ready? So we're going to now capture the filter. Turn it on. Flora.
Still a lot of stasis here, though.
Yeah, I'm just going to pull.
Yeah, I mean, remember, it's occlusive. The catheter is down. There's still lesion, recoil. So the inflow is not clearing off your outflow right now. So that's why you feel a little bit of stasis. But I think once the filter comes out and you prep the distal segment.
Good, right there. A little more.
Just being very gentle, sucking back.
Right there.
So you're going to rewire it, right?
We're going to try to leave the wire down so we don't lose.
Mm-hmm. Yeah, but in this case, I don't think it should be, even if unfortunately something happens, you can still rewire it. I think you've ballooned enough for the wire to recross.
Follow the filter up.
You see filter all the way?
Up.
Yeah.
Okay, go ahead.
Yeah, so this is a very important technique for the viewers to see how you can actually keep the luminal crossing still there with the wire, and at the same time take your filter out under active negative suction, thereby significantly decreasing your distal embolization. The only thing is we can only do this with this EmboShield, the NAV6 from Abbott. If you're using other kinds of filters which are directly attached to the wire, then you can do that.
Spider.
So, yeah, like Spider and other filters. So I think this is the advantage with this filter which we use here. So that gives us a little bit of flexibility and room to do it. So great technique showed by PK and Raman of how to manage this so-called a bump in the road. But he's going to keep the negative suction up there till the time the filter is physically out. And then, of course, they're going to open the TUI, make sure there is no debris at the TUI level, and then probably go from there.
Yeah, so one of the things here is you want to make sure the filter comes out of the device.
Right.
Raman is just going to pull it out. Hopefully it's stuck in the catheter now. So I just pulled it out. Raman will check that out. So what I'm going to do is bleed back the TUI and have Ray flush.
Right. And that's another advantage here as well, the sheath you use as well. In this case, you can unhook the sheath right at the hub, so you can physically, if it gets stuck right at the biggest problem comes in when it's right at the hub and it doesn't come out. In those cases, you really have to open it. So in this case, the Terumo sheath, you can unscrew it and take it out. So that's another advantage. So small things add up, especially in cases like these. So important points and things to remember and notice.
So hopefully we're heroes, not zeros. Let's take a shot here. Let's see.
So good.
Looks like
hallelujah.
Looks like we're heroes here. I hope.
Yeah, you can see the negative shadow going now. It'll be good. Yeah, very nice.
Very nice. Okay, good. So anyway, so we've got a good flow.
Now back to the original question.
So now we'll go now the question is, so it's almost 9 o'clock. So we're going to stay online. You guys, we can sign off if you want. But
we're going to see what your strategy is. We want to see a definite strategy.
So what do you think? So let's do a bold show of hands. Moeen, what's your strategy? You're the data expert.
Right.
What would you do?
So I think at this point we can just directly go with the long supera or just do a DCB and do a supera. I was thinking more like just going with the supera up front because there's lower risk of embolization distally, and you know we
So
had
we have
issues
one
with
vote
that
for
too.
supera plus minus DCB. Ray, what do you think? Ray says DCB supera. Alina, what do you think? She says it's up to us. Okay, Raman, what do you think?
What's in Damien's hands right now?
Okay,
Yes,
Karthik, Raman's doing the right thing. He's
200.
listening to Damien, which is always right.
200.
Karthik, what do you think?
Yes.
I would follow Raman on it, but I would go with DES. So
Okay, we have
be
one
fine.
DS, excellent, and then
That should be
Vishal.
fine.
I agree with him. I'm going to
we
layer it
need a
up with
longer.
DES straight up, and that's it. No DCB
All right.
supera straight up.
All right, so
DS.
let me sum up the data.
so you are the deciding vote.
Yeah.
No. So Raman and Vishal clearly believe in the Japanese
the
PMA,
035.
Silver Japan study, which clearly showed 220 millimeter average length lesion, dialysis patient, severe
No,
calcium,
it's
excellent
035,
outcomes.
that's
There is a little bit of restenosis, as we know, but excellent outcomes in the intermediate term. Both Moeen and Ray believe in a combination of supera with DCB, meaning vessel prep, followed by scaffolding to reduce recoil. I think Raman and I also believe in that. So I think we're going to go ahead and probably decide on this. So first, we're going to vessel prep. So I guess you guys are saying let's do the supera as your primary stent versus the DS, because with the DS you're getting both. You're getting drug and thing. So I guess here, Raman. So I'm going to challenge Raman here. Raman, are you not convinced with your vessel prep? Do you think the Silver PTX is going to recoil, and is that the reason you're going with supera? Because if you look at all the Silver PTX studies, the Japanese PMA, the IDE, it's 1.9% fracture rate at 3 years.
Correct.
After that,
Yeah,
the fracture
exactly.
rate does not change. So you have
Right.
a low fracture rate. Supera, as Moeen said, 0% fracture rate. So is that the reason why you're going, or you're still worried about recoil?
I think with this much calcium that we've prepped it 3 times, we've done with the 7.0 high pressure at the CTO segment, we've IVISed it, we have evidence of short-term recoil, not even long-term, short-term, like immediate recoil. I think at this point, what you need is the high radial force, which is just with the supera, which we don't have with the self-expanding stents.
You don't have 7,250? Okay, they only have 780. Okay.
What about the Rangers?
What about the Rangers? So okay, so that's a great argument. So again, it's 9 o'clock, so we're going to stay on the air. We're probably going to sign off from Karthik and Vishal because they have to go, but they do have clinics and other things. So what we're going to do is, I agree with Raman. We're going to go either with a Ranger or Impact, depending on what we have as our balloon length. We'd like to do this quicker than tomorrow by using 10 80s. So we're going to go with a Ranger 7.0 long, followed by a supera. Now, the challenge here, Raman, spot supera or line the whole thing?
I think you're going to end up having to use a drug-eluting stent system for the proximal segment. I don't think we're going to – I've never personally felt comfortable doing a DCB in the ostium of a lesion, so I think you're going to be committed to doing that. And I think the majority of the issue of the recoil we saw was really just from that 10 to 20 segment. So I think it's going to be our spot supera will be right over there and go with a short drug-eluting census and proximally.
So this is where I want to guide everybody in the audience and look at our algorithm here, Raman, myself, Vishal, and Karthik. What we feel is there's no question 10 to 15 that calcified segment needs to be stented. We're going to throw a supera in. The rest of it, I'm going to let IVIS guide me. So I'm going to do an IVIS. I'm going to look at IVIS. I'm going to say, is there less than 30% recoil after DCB? If there's less than 30% recoil with good flow, I've stented the segment where the recoil is. 7,200, beautiful. So what we're going to do is we're going to use IVIS and then decide whether we're going to stent it. If you look at it, can you play the angio, Moeen, the proximal angio, or Raman? If you look at the proximal angio, it doesn't look to be that dissected. So therefore, I think what we're going to do here is proximally maybe just get away with the DCB, like Karthik said, just be, or Raman said, just be spot stenting in what we're doing. See, it's not that bad.
Yeah,
You could just leave it entirely. You could actually just
leave
go
the whole,
to about
just
like a
put
minus
the
2
stent in the middle of mid area.
Yeah, that's
so
also entirely
IVIS. So
reasonable.
this is where I think IVIS serves you really well. I think with the data that's available showing you that 30% is kind of the golden number for you to say whether that's going to restenose or not with impact. Then I think we go ahead and, I'm going to kind of assume that's the same with Ranger. And if it is the same with all DCBs as a class, which would make intuitive sense, that recoil plays a major role in restenosis, I think then we just stent that 22 to 15 region region that Raman was saying, and then we take a look. So if it's okay with everybody, we're gonna sign off from our audio, but we're gonna stay online for our AV team, continue recording, and maybe just what Raman and I are talking, so that we can finish this, and Karthik and Vishal can head back to what they need to do.
Great job, Raman. Great job,
Raman,
PK.
are you guys okay with that, Vishal?
Yeah, I think that's
Yeah.
a good plan. Perfect.
Okay, good. All right,
That
guys,
was a
so-
great presentation.
Thank you.
So why don't you just tell the next case,
Yeah.
Vishal?
All right. So thank you, viewers, for joining us again. A very good, exciting case, a great start to year, successful results, good techniques, great conversations, data, personal inferences, and tips and tricks, I guess. So we'll be happy to welcome you again on February 28th for our second monthly broadcast, which is Wednesday, 8 o'clock Eastern Standard Time here from Mount Sinai Hospital. Till then, have a good month, and we'll see you again. And also, just to add on, you can see our present cases and previously archived cases onto our website, ccclivecases.org, and you can press on the peripheral tab, and all our cases, including our New York endovascular summit cases, will be there for you to review. Any questions and concerns, please feel free to communicate with us via email, phone call, through the website, and we'll be more than happy to discuss. Till then, have a great day, week, and a month ahead. See you soon.
We're gonna stay on. Can you take the music? Thank you. Yeah, because we're still going to be talking, and I want you to record. So we have the DCB up, Raman, and I think this is the area from 23 to maybe 10 that we should probably stent, right?
Yeah.
And then so right now we're watching the heart rate. Can you show the monitor, guys? The heart rate monitor. Because it's a 7, the patient had pain, so therefore we want to watch for bradycardia. Our team, Mac and Alina, are ready with the medications in case he does get brady. So right now he's developing some PVCs, but no bradycardia, so which is fine. So tell me about DCB timing, Raman. Do you follow the 3 minutes very, very strictly?
I think there are very few things that I follow timings correctly on, and DCB is actually one of them. My wife is very upset about the other.
Right. So